Good evening, everyone. Thank you for joining us. Welcome to Together Facing Lung Cancer. Really appreciate having you here this evening joining us. I am Hussein Borgai. I'm one of the lung cancer doctors here at Fox Chase. I'm also the Chief of Thoracic Oncology. Tonight, my colleagues and I will share some of the exciting new developments in the world of research and clinical practice in lung cancer. I am sorry that, again, we have the program on a virtual basis. We were hoping that we can meet face-to-face personally with all of you like we used to do before the pandemic. But obviously, understanding the current situation, the program had to be virtual. We are desperately hoping that next year we will be able to shake hands and hug and kiss and talk in person with all of you. I'd like to remind you that throughout the program, please feel free to leave any questions that you have in the chat feature on Facebook. We will get to you later in the evening. At our Together Facing events, we have a tradition of honoring those that we have lost to cancer. So in recognition of that, I'd like to ask you to please join me for a moment of silence. Thank you. I'd like to start by thanking our exhibitors for this evening. It is because of their generous contribution and support that we can offer this program free to everyone. Our gold exhibitors are Caris, Foundation Medicine, and Tempus. Our silver exhibitors are Amgen, the Monarch Platform Myoris, Blueprint Medicine, Bristol Myers Squibb, Genentech, Guardant, Janssen Biotech, Lilly Oncology, Natera, Pfizer, Sanofi Genzyme, Regeneron, and Vericet. We would also like to extend a welcome and a very special thank you to our patient advocacy groups, including American Lung Association, the Go-To Foundation for Lung Cancer Research, Lung Cancer Research Foundation, Longevity, and Ride Hard, Breathe Easy for their ongoing support of our community. I want to get the program started. We have 3 speakers for you tonight. We have also asked 2 of our other physicians to join us for the panel discussion when we get to it. But to get us going, I'd like to introduce our first speaker, Dr. Nicholas Boder. Dr. Boder, please.
Thank you very much, Dr. Borgai. It is truly a pleasure to be with all of you this evening. I wish to thank all the hardworking organizers and generous sponsors of this great event. And most of all, I really want to thank everyone in the audience, all the patients and caregivers joining with us this evening. So I'm absolutely thrilled to have this opportunity to speak on behalf of my colleagues and share with all of you some of the exciting work we've been doing here at Fox Chase to better understand and combat the ever-growing national and worldwide problem of lung cancer in never smokers. So this is a disease that is distinct from smoking-related lung cancer, both in its biology and potential treatment options. Many of you watching tonight may know a friend, have a loved one, or may you yourself have been diagnosed with lung cancer yet have never smoked or smoked very little. Most of the general public are not aware that lung cancer can develop in people who have never smoked a cigarette in their life. And in fact, here in the United States, nearly 20% of lung cancer patients do not have a history of smoking. So to put this into perspective, nearly 240,000 people in the US are diagnosed with lung cancer every year. And so 20% of that number means approximately 45 to 50,000 people annually are diagnosed with lung cancer yet have never smoked. This is clearly a huge number and a huge problem. And quite frankly, this problem is even bigger in other parts of the world. For instance, in East Asia, where close to half of the patients they see there in their clinics with lung cancer have never smoked. And what is especially concerning and quite frankly scary is that the number of lung cancer cases in never smokers continue to increase. And we really do not know what is driving this. What we do know is that lung cancer in never smokers occurs more often in women and tends to be diagnosed at younger ages. However, in the end, this cancer does not discriminate on who it inflicts. And we see both men and women and both young and old with this disease. Given the magnitude of this problem, Dr. Joe Treat, one of our senior thoracic oncologists, established the Never Smokers Lung Cancer Clinic here at Fox Chase over 3 years ago. And this unique clinic is one of the only of its kind on the East Coast. And in this clinic, we provide dedicated care to patients with this disease, make available new and exciting clinical trials, and provide unique opportunities for our patients to get involved with many of our research endeavors. As part of this clinic, we developed a new immunotherapy investigator-initiated clinical trial geared specifically to lung cancer patients who have never smoked, or for patients with tumors that possess an EGFR mutation, this latter mutation being one of the common mutations we find in lung cancers from never smokers. We first opened this trial here at Fox Chase in August of 2019, and this trial has since expanded greatly and is now open at 15 other cancer centers across the country, including notable centers like Johns Hopkins, Stanford, Northwestern, and many others. In addition, the true cornerstone and foundation of this Never Smokers Lung Cancer Clinic is the collaborative work that is being done by thoracic oncologists like myself and Joe Treat with basic science researchers. Really, any past, present, and future medical breakthrough is largely possible through the relationships formed between clinicians and scientists. Fox Chase, quite frankly, has a long history of this. And work we do as part of this Never Smoker Lung Cancer Clinic is no different. We have partnered with Dr. Margie Clapper, Deputy Scientific Director and Basic Science Researcher here at Fox Chase. And given the greater percentage of women impacted by this disease, Dr. Clapper has long focused her research on the role of estrogen and other hormonal factors on lung cancer development. Our collaborative clinical and laboratory partnership has led to a number of striking discoveries. One of them being that how an individual metabolizes estrogen and the extent to which toxic, carcinogenic estrogen metabolites are created may be one of the most important causes of lung cancer in women and men who have never smoked. Ultimately, inhibiting the creation of these carcinogenic metabolites may be a promising means to prevent and treat lung cancer in never smokers. And this is an area of active current research by our team. Truly, such discoveries are only possible through the involvement of many of our patients that we see here at Fox Chase, who have all kindly participated in our research studies. And in fact, many of you in the audience tonight may have been approached by me or other members of our team during your clinic visit to take part in this important work. I want to say thank you to all of you. And please know that none of this work is possible without you. I would also like to add that if anyone watching tonight would like to learn more about this research or would like to participate in our work, please reach out to me. This research requires the participation of both patients as well as those without cancer. So spouses, caregivers are all potentially participants in our studies. And you may be out there watching tonight and we are piquing your interest with this. Please call us so that we can get you involved. It is only together that we can strive to build upon our prior discoveries with the ultimate hope of finding new ways of treating lung cancer in never smokers and perhaps one day being able to prevent it. Thank you very much.
Thank you very much, Dr. Boder. Appreciate you being here and informing us about this important initiative. Next, I'd like to introduce Dr. Jessica Bauman to cover her area of research. Dr. Bauman.
Hi, Dr. Borgai. Thank you so much. And thank you so much to our audience for participating in this with us tonight. I wanted to talk about a couple of different things in regard to lung cancer. One is just a brief rendition of facing a new diagnosis of lung cancer, as many of you in the audience, I imagine, are facing either yourselves or with a loved one. And then turn our attention a bit to supportive care research here at Fox Chase with an eye to early palliative care, as well as a nutrition study that we're currently doing here. So as you well know, as Dr. Boder has just said, near 250,000 Americans will be diagnosed with lung cancer this year. And we know that lung cancer remains the leading cause of cancer death in the United States, claiming more lives than colorectal cancer, pancreatic cancer, breast cancer, or prostate cancer. We know it's the leading cause of cancer death in women, and that in fact, nearly 20% are never smokers, as Dr. Boder highlighted. We also know that lung cancer is the least funded cancer in terms of research dollars. But we also know that there have been truly remarkable changes in cancer treatments as well as supportive care over the last decades. So as you all likely know, what do we do with in 2021 for a new diagnosis of lung cancer? Well, certainly there are a myriad of tests that all of you, or some of you may have undergone or watched a family member undergo in regard to biopsies, imaging, CAT scans, MRIs, PET scans, as well as quite a bit of specialized testing in regards to molecular testing and something called PD-L1. But all of that testing gives us the view into a cancer to really help us decide what treatments make the most sense, whether there are standard treatments that are appropriate, surgery, radiation, or some kind of systemic therapy, being chemotherapy, immunotherapy, targeted therapy. And then it also allows us the insight into whether clinical trials might also be options in terms of how to really offer you the best treatment for the lung cancer. One of the other very important parts of a lung cancer diagnosis is symptom relief. And I think the other part that we're going to get to more in terms of what I'm going to talk about is really the supportive care, as well as even the nutrition aspects of lung cancer. So in addition to the testing that has to happen when there is a new diagnosis of lung cancer and treatment decision, I will say that all of us have experienced how overwhelming a new diagnosis of lung cancer can be. We know that it's overwhelming because of the complex medical decision-making that happens in our clinics, right? The testing that we send people for, the myriad of physicians that you have to meet and understand the role that they may play in your care. It really is like learning a new language for patients and their families when they're diagnosed. We also know that there are significant physical symptoms for patients who have a lung cancer diagnosis. Things like fatigue, shortness of breath, cough. We can also see pain and weight loss, a decreased appetite, and sometimes difficulty with being able to do just regular activities of daily living. We also can see significant psychological symptoms with a lung cancer diagnosis: distress, anxiety, depression. We know that up to a third of patients can meet the threshold of sort of the clinical threshold that we think about for mood symptoms when they're diagnosed with lung cancer. And we know that it's not just the patients themselves, it's also the families. We know that caregivers also can experience significant symptoms when a patient has a lung cancer diagnosis. They can experience distress, sadness, fatigue themselves, difficulty sleeping. And for caregivers, it's much more common for caregivers to have more symptoms when the patient themselves also has a high symptom burden. And so we know this isn't just about the patient, this really is about everyone. And we also know that there can be significant financial implications with a lung cancer diagnosis. We know that up to 50% of our patients report financial stress, which can be more common in younger patients. And the out-of-pocket expenses with a lung cancer diagnosis is highly variable, which can bring specific burden to our patients. And so with all these problems that we talked about, What can we do to enhance the supportive care aspects of what we do for patients and their families? And so certainly, I think that you've heard in many of our events, as well as in what Dr. Boder said, how important it is to figure out the best treatment we have to offer for our patients, right? That is our number one most important goal, is to find the best treatment to give patients the longest and best possible life that we can offer from that is medically possible. But I also think that just as important as the chemotherapy or radiation or surgery that we're delivering is the supportive care that we're delivering. And interestingly, just like there are clinical trials for new drugs, there are also clinical trials that are looking at new ways to deliver care, and specifically with an eye of supportive care or even nutrition, that I want to talk a little bit about today. So what if I told you there's an intervention to help patients with lung cancer that can improve quality of life, improve quality of care delivered, decrease depression, decrease anxiety and post-traumatic stress, improve coping, improve communication about care, decrease caregiver distress, and improve survival? What is this intervention? If this was a drug, everyone would say, sign me up. Interestingly, all of these things have been shown when we integrate an early palliative care team into the patients with a new diagnosis of advanced lung cancer. So it's not just a drug. The supportive care that we're delivering is just as important and offers a significant benefit that is critical to understand. We know that there's been quite a bit of research over the last 15 years in lung cancer that demonstrates benefits of involving an early palliative care team in the different aspects that we just talked about. So often people will say to me, well, what is palliative care? And I think it's important for me to talk a little bit about that palliative care is a specialized medical care for people living with a serious illness. Certainly, I think lung cancer falls into that category. It's a type of care that's focused on providing relief from symptoms and the stress from the illness, which is exactly what our patients can experience. And it really is the goal of palliative care is to improve quality of life for both the patient and the family. I think what you may also be asking me and have spoken with families about is that there can be some misperceptions about palliative care that are important to talk about. Sometimes people think that palliative care means that it's really just for patients who are at the end of life. Sometimes people think palliative care is the same as hospice care. Sometimes people think it means that people are giving up. And sometimes it means that people think that palliative care means they can't receive cancer treatment. But what's really important to know is that really none of those things, in fact, are true. That what palliative care is an extra layer of support for patients and families. It's a team that consists of a physician, advanced practitioners. Often there are several nurses on the team, social worker, chaplain, and their focus is really on providing relief from symptoms and the stress of an illness, where the goal is to improve quality of life for both the patient and the family. And really, it's based on the needs of the patient and family and not on the prognosis. And it can be appropriate at any time in a serious illness, even if no matter what the type of treatment that someone is receiving. What's important to know is that there have been clinical trials, so just like drug trials, there have been clinical trials that show in lung cancer for patients who are randomized to integrating an early palliative care team into their care from the beginning of a diagnosis, those patients have just what we just said: improved quality of life, quality of care, improved mood, improved coping and communication, and even improved survival, compared with patients who are just receiving their care from their oncologist, which is not to say negative things about oncology, but I think it's important to note that it really is about complementary care that our patients can receive, that really you want to be thinking about the diagnosis from multiple different directions. And so now that we know from the research that we've seen that palliative care can be effective in terms of many aspects for our patients and their family, the current issue with palliative care is that there aren't enough palliative care physicians nationwide for all patients to see this team as regularly as they saw them in the kinds of trials that we've done. And so one of the questions that has become really relevant, even more so in COVID, is, are there novel ways to deliver palliative care, such as telehealth? And so right now we are participating in a nationwide study that's looking at this question. The study's called REACH-PC, and some of you on the conference may be involved in this study. But the purpose of this study is to determine whether telehealth visits with our palliative care team is really equivalent to in-person visits. We know the benefit of in-person visits, and we hope that telehealth really, in fact, is delivering the same type of care. But this study will help us determine whether that is true, and then ultimately be able to think creatively of ways to get this type of model, this model of care to more patients who have lung cancer, given we know how helpful it can be. And so interestingly, the study actually started before COVID, but I think it's become even more important because so many of us have adopted telehealth just sort of like with a snap of the fingers. And I think it will teach us tremendously how telehealth is delivered and which aspects are the same, which aspects are different moving forward. And the last thing that I also want to briefly talk about is also this question about nutrition in lung cancer, which is a second supportive care study that we have. So as we talked about the many different side effects and symptoms that patients have, we also know that patients with lung cancer can be among the most malnourished of our oncology patients, and up to 50, even up to 70% of patients can become malnourished during their lung cancer treatment. We also can see unintentional weight loss very commonly. Up to a third of patients can have significant weight loss, even greater than 10% of their body weight. We also know that with nutrition and that losing weight and malnutrition can truly impact patients' longevity. It can cause significant treatment interruptions, admissions to the hospital, as well as worsening of side effects, and it can even increase the risk of recurrence. We also know that for people who are malnourished, that their tolerance for chemotherapy and radiation is also significantly lower, as well as their general performance and quality of life. And so there have been some small studies looking at different kinds of nutrition interventions in lung cancer to see what can we improve. All of which are fairly small, and there's some mild improvement with a couple of different interventions: fish oil, protein supplementation. But two of the studies that have shown some benefit as well are improving counseling in regard to sort of really direct counseling about nutrition, as well as medically tailored meals. And so one of the other supportive care studies that we have for our patients for a new diagnosis of lung cancer is something called the Nutricare Study, which is a study that is looking at the role of nutrition interventions in terms of improving nutritional intake, minimizing treatment toxicities, and then as well as things like hospitalizations. And the study is a randomized study, as both of the studies we're talking about are, between a excellent nutrition information, as well as the second arm is the information, but this is paired with nutrition counseling, as well as medically tailored meals from one of our partners in Philadelphia. And this is a study that we're collaborating with multiple institutions across the country as well. And so we're excited to be able to offer these studies, not just the direct studies that we use for the treatment of our patients in terms of their diagnosis, but also for the supportive care aspects that are just as critical to their cancer diagnosis. So please ask your oncologist if these are something that you might be interested in participating in. Certainly, we very much appreciate everyone who is in fact already participating in these studies, as we hope that it will continue to help all of our patients and their families.
Thank you, Dr. Bauman. That was very nice. Glad that we were able to get that information communicated with everybody. Thanks for being here. Our next speaker is Ms. Donna Edmondson, a nurse practitioner within the pulmonary division, and she'll talk about our tobacco treatment program.
Hi, and Hi, and thank you very much for having me here today. I'd like to talk about our tobacco treatment program here at Fox Chase Cancer Center, and also touch upon the new lung screening guidelines that just came out. So in regards to tobacco treatment program, I just want to review that within the last year in 2020, Fox Chase Cancer Center was a recipient of the NCI C31 grant through the Moonshot Initiative. We were excited to receive this grant, which enabled us to expand our program and actually make some changes within our computer system, also our data collection, and develop a case management system. What does that all mean? That means as a new patient coming into Fox Chase, as you're identified as either an active smoker or someone who's quit within 30 days, that information is forwarded automatically to a registry, and you will be contacted by one of our tobacco treatment specialists to talk to you whether or not you would be interested in quitting smoking, or if not actually quitting, at least decreasing the amount of cigarettes that you smoke. We do know, and research does show, that there is an overall benefit to either stopping or decreasing the amount of cigarettes smoked after having a diagnosis of cancer, and particularly lung cancer. So in regards to that program, what we do offer is right now we've converted, because of COVID, over to telemedicine visits, which would be either by phone or by video. We also do in-person visits. We have a comprehensive program where you meet with a tobacco treatment specialist, and that you will be meeting with them on a regular basis, and it's consistent. What we hope to be able to do is coordinate your schedules with your other clinicians, so that this is not bringing you back to the center unnecessarily, which could add additional stress. We are also able to extend our services to any families and friends. So we're very pleased with the progress that we have made, and we also are working on expanding the program across our health system. Also, exciting news in regards to lung cancer screening. The new guidelines now are for individuals from between the ages of 50 and 80, which is different than what they were prior. Prior, they were ages 50 to 70. Now they're also involved with individuals who have smoked a 20-pack year history, who have a 20-pack year history of smoking. And what does that entail? What does that mean? That means if you smoked 1 pack of cigarettes for 20 years, or if you smoked 2 packs of cigarettes for 10 years. Also, if you're an active smoker or quit within 15 years. Our program here at Fox Chase Cancer Center is based on a same-day visit where you come in, you meet with a specialist who is specific interest is in lung cancer screening. We go over the risk and benefits of a lung cancer screening. You get your CAT scan done. You go into the machine fully dressed. The CAT scan you're in the scanner for just a few minutes. You come out, you come down to clinic, and we actually, within an hour, will go over your lung cancer, your CAT scan results, and review the images. And at the same time, if you are continuing to smoke or an active smoker, or you're concerned about relapse, we can also have that discussion and talk about any other concerns that you may have at that time. So there are 2 programs that we're expanding on. And if you have any additional questions, you can let me know.
Wonderful. Thank you so much. Appreciate you providing the update for both of these important programs. So that ends the presentation part of our program tonight. I'd like to open the program now to questions from our audience. Again, please use the chat function in Facebook to ask your questions. If we run out of time, I promise we'll get back to you with an answer, but please go ahead and put your questions in the chat function. For this panel discussion, I'd like to introduce three other colleagues. Dr. Samira Kumar from the Department of Radiation Oncology here at Fox Chase. Thanks for being here. Dr. Roman Petrov, Division of Surgical Oncology, Thoracic Surgeon. Hello, thanks for being here. And Ms. Lisa Atkins from our Social Works Department. Thanks for being here, Lisa. So we have a couple of questions coming in, and since we have our expert radiation oncologists and surgeons, I'm going to start with one question for each. Dr. Kumar, we have a question asking if there are any new advances in the way radiation is used to treat lung cancer. I wonder if you can expand a little bit on that for us.
Yeah, so actually radiation in lung cancer is really exciting right now. And part of the reason is because we're using more advanced techniques. So in the past, we would only be able to treat, stage 3 lung cancers with 6 weeks of radiation therapy. Now we're seeing that we can hypofractionate some patients, or we can deliver the same dose in 3 weeks for certain select patients. Additionally, in the past, whenever patients had metastatic disease, even if they only had a few sites of disease, we wouldn't offer radiation to these patients. We would say, the cat's out of the bag. But there have been more and more studies that show a benefit in oligometastatic disease. That means disease that has just spread to a few sites, or even oligoprogressive disease, which means disease that's only progressing in a few sites when you treat it with radiation. So the indications for radiation have really expanded in just the last couple of years, which is really exciting because these have benefits in terms of survival and quality of life for the patients.
Great, thank you. Dr. Petrov, when is surgery an option for treatment of lung cancer?
Thank you, Dr. Borga, and thank you everybody for joining us today. Surgery has seen significant advancement over the last several decades to years. And now we perform surgery in a minimally invasive fashion. The majority of the time, surgery is performed for early stage cancers, that is cancers that hasn't spread anywhere. And with surgery, we can completely remove the disease and patient can be cured. However, with the advancement of the surgery can be performed for more advanced local and regional disease, and very advanced oncologic resections can be done, things like sleeve resection, humanectomies, reconstructive surgeries. So surgery really offers option at curative intervention for patient, means your patient completely cancer-free. And nowadays we perform it in a minimally invasive fashion, which translates for the patient better outcomes with less pain, faster recovery, and early return back to normal life.
Can you expand on the minimally invasive surgery a little bit more for our group here, please?
Absolutely. Traditional thoracic surgery was performed through what was called thoracotomy. This is a large incision on the side. And it appeared to be, at least in the past, it was quite a painful procedure, and recovery from the surgery was prolonged, long stay in a hospital, and then long recovery and return to back to normal life. Now we perform minimally invasive, either what's called VATS, video-assisted thoracic surgery, or robotic surgery, where essentially the same level of procedure, oncologic resection, can be performed through small incisions, frequently either video-assisted with the surgeon at the bedside, or robotic when a special surgical console robot, Da Vinci robot, can be used to perform the same complex resections for the cancer through small incisions. And usually patient spend much shorter period of time in the hospital, frequently length of stay in a matter of 2 to 3 days, and recovery is faster. And in those patients who require additional treatment after surgery, be it radiation or chemotherapy, they can start those treatments faster and sooner as well.
Thank you. It's very helpful. Ms. Atkins, we have a question regarding supportive services. And can you speak a little bit about what supportive services are available for someone facing a lung cancer diagnosis?
Sure, thank you. Social work is here to help patients with all of the support aspects coming at them, whether it's new diagnosis, progressive disease, or if their patients are admitted to the hospital. And we are there. We provide individual and family counseling. We work closely with all the different nutrition, physical therapy. We're lucky enough to have psychiatry as well. So we do work very closely in the clinics, but there are different community resources that we refer to for support groups and connection with other patients to get perspectives on the patient-to-patient perspective and talking to other patients that have been there going through the same situation. Great, thanks.
So we now have some very specific questions for some of our speakers. So I'm going to start with Dr. Boder. The question has come in: what would be the best way to get involved in the Never Smoker study and research? So perhaps you can go over that one more time for us and tell us what else can be done for those who are interested in participating.
Yes, no, thank you so much for that question. I truly appreciate it, because certainly this is work that we're all very passionate about at Fox Chase, and it's only made possible with you know, the people out in the Fox Chase community getting involved. And so ultimately, if you want to get involved, especially as either as a patient participant, I think if you're seen by any of the oncologists here at Fox Chase, not just myself or Dr. Treat, but I mean Dr. Borgay, Dr. Bauman, Dr. Edelman, all of us are all part of these studies. So if you're a patient who fit the kind of the profile that I was describing, whether you've either you know, never smoked, and that's defined as smoking less than 100 cigarettes in a lifetime, or if your particular lung cancer has one of those kind of typical driver mutations that we see in never smokers, whether it's EGFR or ALK or ROS1 or really any of them. And certainly, you know, your individual provider can kind of help talk to you about this and guide you. If your cancer has, in fact, have one of those, then as a patient, yes, you most definitely qualify for some of our studies. And so those studies include some of the estrogen work that I was starting to tell you about. Those are kind of where we had that partnership with the laboratory group, where we would then ask for the collection of specimens. And truly, it's actually quite straightforward. It's usually just a urine specimen or a blood specimen. We also sometimes use the tissue specimen that may have already been previously collected in a biopsy. It doesn't necessarily mean you need to have a new biopsy or anything else done. So it's generally non-invasive tests, along with a short survey that you complete. So please, I encourage you, you know, speak with your individual, you know, thoracic oncology providers and ask them about the study, and then they'll get in contact with me, and I can work with you to get you involved with this. And it's really just, it honestly just takes about 20 to 30 minutes at the very most to kind of collect these specimens and then collect kind of the survey data. And then for other people who might not necessarily have cancer, but are kind of the caregivers or spouses or friends of patients here at Fox Chase who are listening right now, many of our studies, the only way we're able to figure out these relationships between certain risk factors, whether it's estrogen metabolites or anything else with never smoking lung cancer risk, is having people without cancer also getting involved. So people without cancer is just as important as far as collecting, you know, your urine or blood specimens or other things to be able to try to further investigate this. So please, I greatly appreciate that question, and please, if you're interested, please contact us.
Great, thank you. Kumar, I'm going to come back to you. Would you be able to talk a little bit about what methods and strategies and techniques you use now in your everyday clinic to minimize the potential side effects of radiation to normal organs, and what strategies you've been happy with, and what kind of research is going on in that area?
So I think the question is a two-part question. One, how do I actually minimize the dose to the organs? And then two, how do I minimize side effects? So the first part, you know, when we look at radiating lung tissue, we have to be very cognizant that unlike most tissue in the body, that tissue is actually moving throughout treatment. So as patients are breathing, their lungs move, and therefore the tumor is moving as well. So when we treat a lung cancer, we actually have to get a special scan called a 4-dimensional CT scan during our planning. We also use immobilization techniques like molds of the body to keep the patient in place. And very rarely, but we do sometimes use abdominal compression to limit the movement due to respiration. We then use advanced techniques like IMRT or SBRT. Most of our patients, especially those with stage 1 through 3 cancer and then oligometastatic stage 4, will get either IMRT or SBRT. And what that is where we actually aim the radiation beams and kind of shape it around the tumor. Humans themselves actually don't do the planning. We have computers and AI algorithms that will find the best plans for us. And in that way, we can minimize doses to the normal structures. In the clinic, I've found that clinically, providing great supportive care throughout the patient's treatment is really key to kind of mitigating side effects. Prevention is always way better than treatment, and always making sure patients are eating and drinking well will prevent esophagitis and further fatigue down the road. So I'm always a big advocate of getting services like nutrition on board early if patients are losing weight. And I spend a lot of time counseling my patients about those kinds of things.
Great, thank you, appreciate it. Dr. Bauman, I'm going to ask you to comment a little bit about this particular question. So the question basically says, what are you excited about in terms of treatment for lung cancer that wasn't available 5 years ago? And what do you see coming while we're talking about that? Because you're heavily involved in many of the clinical trials that we do in the therapeutic area also, in addition to what you mentioned regarding the supportive oncology protocols that you are running.
So I think that certainly over the course of the last 5 to 10 years, we've seen remarkable changes in terms of what has been approved in lung cancer. And it seems like every 2 to 3 months, there's something else that has been approved. I think the most exciting drug, I would say, in the last 6 months has been sotorasib, which is a KRAS inhibitor. I think targeted therapy really there are 2 areas that have really revolutionized treatment over the last many years. One is targeted therapies, and which goes into this idea of doing what we call molecular testing on all of our patients who have a new diagnosis of non-small cell lung cancer to look for specific changes in their tumor that are associated with potential treatment responses. And so these are what Dr. Boder has been talking about: EGFR, ALK, ROS. Those are often found in patients who are never smokers, but there are also other types of mutations that are found in patients who are smokers as well. The most common of which is actually KRAS. We know that 25% of patients who have adenocarcinoma have KRAS mutations specifically, and it is the first time we have ever been able to target KRAS. And so to see a KRAS inhibitor approved in the last 6 months, I think is one of the most exciting things that we've seen this year. Not only do we, but it's KRAS, it's also, we've seen 2 specific RET inhibitors approved in the last year. And so the world of targeted therapies has really exploded, where we initially just started with EGFR and ALK, which were sort of the 2 first stories that started in between 2004 and 2007. But now it has many, many, many different treatments for very specific alterations. And then the second area of extreme interest is immunotherapy, which Dr. Boder also alluded to. And immunotherapy has really completely changed how we've treated lung cancer. When I graduated from fellowship, in fact, I like to say, when I was in fellowship, I treated 1 patient with immunotherapy, 1 patient. And now I treat almost all of my patients with immunotherapy. But immunotherapy still is not a slam dunk for everybody. And in fact, for many people, immunotherapy doesn't have a great response for their cancers. And so there is a lot of ongoing research to figure out how to augment the responses to immunotherapy. And we have many different clinical trials that are in this area as well.
Great. I think what you just mentioned about targeted therapy also underscores the importance of these genetic testing that we do on the tumors. And now, the terminology is a little bit confusing. So perhaps we can have a little discussion about that. So we call it genetic testing, but we have to clarify it's genetic testing of the tumor, not the traditional genetic testing looking for hereditary diseases. And also we throw around this terminology, next-gen sequencing or next-generation sequencing. So between the three of us, you, me, Dr. Boda, and whoever else wants to participate, I'd like to have a discussion about how we look at this concept of molecular testing, and I think it's a more accurate terminology. So perhaps you'd like to start with how you look at this and what's the importance of it for our patients and why do we emphasize this so much? Dr. Bauman.
Sure. So as we briefly mentioned, molecular testing really has revolutionized treatment. And so we used to treat everybody with lung cancer with what we called a platinum doublet, right? 2 chemotherapies that we treated them essentially once every 3 weeks, and everybody got 2 chemotherapies, no matter what their cancer was. But since that time, by really understanding both the histology, so what the tumor looks like under the microscope, but also understanding the DNA of the tumor and what drives that tumor to grow, has completely changed our understanding of how every single person's cancer, in fact, is different. And it really has allowed us to individualize. So this molecular testing has allowed us to individualize the treatment for our patients with lung cancer. And so when someone comes into me with a new diagnosis of non-small cell lung cancer, if it has spread metastatic, again, our treatment is completely different than what it was 20 years ago, because we need that information and we need it as fast as we can, right? Because it completely changes what I'm going to offer for treatment. Whether I'm going to treat somebody with immunotherapy alone, whether I'm going to treat somebody with chemotherapy and immunotherapy in combination, and whether I'm going to treat somebody with a multitude of these different, very specific targeted therapies that are pills. So so even though it used to be, oh, yep, you've got stage 4 lung cancer, it's not that at all anymore. It's very individualized based on all of these different factors that we've said. And interestingly, these things can also change over time. And so it is something that we're not just getting once, but in fact, we're often getting multiple times throughout someone's diagnosis to really understand the biology of their cancer.
Great, Dr. Porter, would you like to add something to that?
Yes, please. I completely agree with what Dr. Bauman just described and fully echo that. And I'd also like to add, I mean, despite what we see on television, all the commercials, immunotherapy is not necessarily for everyone in the first line setting. And certainly I've had a lot of patients who come to me saying, I want immunotherapy. I see all the commercials. This is what my uncle got. This is what it is for me. But that's not always the case. And kind of like what we've touched on before, especially in patients who are never smokers, those with these particular molecular mutations in the tumor, just to kind of echo what Dr. Borgay said. And this is actually a point of confusion sometimes when I talk about, DNA-based testing or genetic testing. This is not mutations that are necessarily in your own personal DNA or something that you could potentially pass on to your children or something that your parents have or your brother or sister might have. This is something that's unique to your tumor. And the reason why that's important is because, like Dr. Bauman just said, there are these really potentially effective oral targeted agents for these particular mutations. And if your tumor has one of these mutations, without a doubt, giving one of these targeted oral therapies is way to go. Immunotherapy is not the answer in those particular situations. And so to kind of circle back to talk about kind of the molecular testing, the DNA testing, it's important that we have that information early and quickly. Ideally, before a patient even sees us in clinic, it would be wonderful to have that information beforehand so that we can make the very best treatment decision if you were to have metastatic non-small cell lung cancer. So in addition to kind of the tumor-based testing, which we've talked about, there's also a role for a blood-based or liquid-based, a liquid biopsy. And for those who might not be familiar with that, if one were to have kind of widespread metastatic disease, frequently the tumor itself is shedding cancer cells into the bloodstream. And there's now technology where if we draw that blood, we're able to actually examine those tumor cells circulating in your bloodstream and see whether or not your tumor itself has one of these important driver mutations, which of course greatly dictates what sort of treatment we're able to offer you in the first line setting.
I'm so glad you brought up the idea of the liquid biopsies. Definitely a significant improvement and advancement that we've seen in care of our patients with lung cancer and many other cancers, to be honest. So it is an important component of what we do now in our clinics and helps us tremendously. So thanks for discussing that. I'm going to move on to another question. This one, I'm going to ask Ms. Edmondson and Dr. Petrov to comment. We're going to start with Ms. Edmondson first. So the question says, if I have a CT that shows a nodule in a former or a current smoker, how do you assess this nodule and what are the steps that you take to ensure that it is not malignant or it is malignant? So perhaps we can start with you, Ms. Edmondson, and then Dr. Petrov can provide additional comments.
So I guess an example that I could actually use is if a patient comes in with a low dose CT of the chest for lung screening, and that individual comes in with a what we call a sub-centimeter nodule, which would be anything under a centimeter. So an example would be if they come in with a 4 millimeter, 5 millimeter nodule. What we do at that point is that we assess the individual's risk factors, not only their tobacco use, but any additional risk factors that they may have. If they have a history of a COPD and or any additional exposures. Then we also look at the nodule itself, the characteristics of the nodule, and where the nodule is actually located within the lung fields. Then what we do is we have specific guidelines that we follow for lung cancer screening. We use what we call lung rads, which will give us specifically, it breaks it down into characteristics of what we call low risk or high risk. If someone's a former smoker and has smoked for 20 pack years, or an active smoker, or quit within 15, they would be considered a high risk individual. And based on the guidelines, and if the nodule is below 6 millimeters, then we would bring the individual back with what we call a short interval scan, and that would at that point be a diagnostic CAT scan. And that individual would come back. It could be within, anywhere between 3 to 6 months, based on what the lung rads recommendations are. Now, if an individual comes and we'll say, for an example, that they have a 1 centimeter nodule. At that point, again, we look at the individual, we look at the risk factors, we're looking at the characteristics of the nodule itself and where it's located. And at that point, what we would do is we would consider potentially ordering additional testing, such as possibly a PET scan. Possibly what we would also look at is scheduling for a biopsy, which potentially could be what we call an EBUS. It's where we do, it's actually done under a bronchoscopy with an ultrasound and a navigational system, which we can locate the nodule and obtain additional tissue for diagnosis. And at the same time, we can complete staging. But one of the most important things that we have to also consider at Fox Chase, and that we work as a team, is that we have a comprehensive tumor board meeting that we can discuss these cases and review the nodules and have our radiologists review and the team, and we come up with the best recommendations using also our NCCN guidelines.
Great, thank you. Dr. Petrov, any additional comments?
Yes, thank you again, Dr. Borga, and I want to thank Ms. Edmondson for this comprehensive review. The good news that from all the nodules that accidentally found on a CAT scan, done for other reasons, only a small proportion of those actually will turn to be something concerning like a malignancy, including lung cancer. However, the bad news that some of those actually will turn out to be those. And we have the team approach. We evaluate every patient individually. the whole workup is guided by characteristics of the nodule and of the patient to actually decide, is it something concerning and we have to act on it. And honestly, to the point, if patient needs to have surgery by me or one of my partners, or is it something that we can relax? And honestly, frequently patient preferences play a major role in the decision-making process, because oftentimes we offer patients to watch, let's say, get CAT scan in 6 months, and some patients say, no, I want to have a definitive answer right now, and they prefer to get a biopsy. And some patient opposite, they say, I don't want to have anything done until I'm sure it is something bad, and we offer, repeat CAT scan in a few months. So it is always a very comprehensive decision of all the providers, tumor board. We discuss every patient individually and come up with individual plan of care. And I want to thank all my partners here who contribute to this decision process.
Thank you. And I think it is important for us to emphasize patient preferences obviously are significant, always taken into consideration when we make any kind of decision in this disease. So unfortunately, we're running out of time. We have one more question. So I'm going to try to take this one. Is molecular testing important for guiding small cell lung cancer treatment options? Unfortunately, no, we have not been able to find the driver mutations that we talked about in the non-small cell lung cancer world for small cell. There is a tremendous amount of research now, thankfully, ongoing in the world of small cell. I can tell you that we are identifying 4 different subtypes of small cell gradually. Has not become part of the standard of care. We've not developed specific treatments for these various subtypes, but that doesn't mean that in another year or 2 we won't be there. So I think that is one area that we are hoping to have significant improvements in the next 2 to 5 years. So stay tuned for that. The next question, again, we have just a couple of minutes. Maybe Dr. Border would like to respond to this. How does one develop an EGFR exon 19 resistance during treatment? And please keep in mind that we only have a couple of minutes, and I know it's a longer answer possibly.
Yeah, no, certainly. No, thank you for that question. So certainly EGFR is a type of protein that kind of sits on all cells. It's called a transmembrane protein, and actually we all have it. But however, when people develop lung cancer from it, it's because there's a mutation in that particular protein. And so I almost like to think back to our kind of early kind of biology classes from high school. You're then putting kind of selective pressure on that by giving this particular oral drug that's there to treat the cancer. But over time, the cancer kind of evolves and develops these mutations, that what we call resistance mutations, where that earlier drug is unfortunately no longer effective. And so there are these resistance mutations, and granted, it's probably the minority of cases, but there are some that are potentially targetable, whether it's part of clinical trial or other kind of off-label use. And as part of the care that we give here at Fox Chase, we frequently do a repeat biopsy, whether it's a liquid biopsy that I was talking about or an actual tissue biopsy, to look for some of those resistance mutations like an EGFR exon 19 to see if there's another drug that might also work to kind of help target that.
Great, thank you. Unfortunately, that's all the time we have for the questions now. Thank you for all you for participating in the program. Thank you for spending your evening with us, and thank you for all the questions. And I also like to thank all of my colleagues who participated tonight. I really appreciate everyone's support. We have 2 more virtual together-facing programs taking place in this fall. One is pancreatic, and the other is neuroendocrine tumors. Please check the Facebook page and our website for more information regarding these 2 programs. I'm now going to turn this over to my colleague, Lisa Atkins, to close out the program for the evening. Lisa?
Thank you, everybody, and thanks for joining us again this evening. It's always a special program for all of us providers to share with you, and something I've done for years. I always like to end with a positive, hopeful statement. So bear with me with my cheesy quotes. This one is: cancer is powerless to cripple love, to shatter hope, to corrode faith. Cancer is powerless to eat away peace, to destroy confidence, to kill friendship. Cancer is powerless to shut out memories, to invade the soul, to quench the spirit. Cancer cannot, will not lessen the power of a mortal life. Thank you, everybody. Cheers, take care, and ask questions, send us information, and reach out to all your providers for anything we can do to help you. Thank you.
Thank you.
And everyone.
Thank you.